All right, everybody, we're going to get started early. Welcome to CPC. Happy Friday to everybody. We have a great case for you guys. Our one-liner for today is a 57-year-old female with past medical history of Crohn's disease, with perianal involvement, status post-diverting loop colostomy, rectal cancer, status post-radiation and resection with colostomy, DVT and PE, status post-IVC thrombectomy, and left iliac stent placement, and history of recent C. diff, colitis, presenting for diarrhea, abdominal pain, and abdominal swelling. We have a phenomenal expert clinician here with us, Dr. Elizabeth Blaney. Dr. Blaney is Associate Professor of Medicine here in the Division of Gastroenterology. She did her medical school at The Ohio State University and then did her residency here with us at Barnes Jewish Hospital. She subsequently then did her GI fellowship at the University of Pittsburgh. Dr. Blaney has clinical interests in women's health and GI, advanced disorders of the GI tract, including amyloidosis. She's heavily involved in medical education, med ed research, and she serves as APD of the WashU GI Fellowship Program. I've had the distinct pleasure of working with her in clinic, and she's taught me so much about medicine and GI. It's closing, full circle moment having you here as a discussant. So thank you so much, Dr. Blaney. Let's get back into our case. So 57-year-old female, past medical history of Crohn's disease with perianal involvement, status post colostomy, the rectal cancer, status post radiation resection, DVT and PE, status post IVC thrombectomy, left iliac stent placement, and history of recent C. diff, colitis with diarrhea, abdominal pain, abdominal swelling. I know that you had some initial thoughts you wanted to share.
Yeah, my first thought is that's a pretty meaty one-liner of a really sick patient. I'm kind of at first like, are we really going to give her more problems than what she already has? So, first things first, when I hear all that, I'm automatically thinking this may be something bad happening with what we already know about, and probably going right to the top is maybe bad C. diff, because that was temporarily the most recent problem. With saying that the abdomen's swelling, maybe we're even talking about toxic megacolon. I'm, just very worried about this patient in general. But also, could this be bad Crohn's disease, increased inflammation, other complications, stricture, abscess, perforation? Patient has cancer too, so is it a complication of the malignancy or a complication of the treatment, chemotherapy complications or radiation complications? And then also, this thrombophilia disorder, which, can go along with these other bad comorbidities. Maybe there's a new clot burden somewhere causing gut problems. Maybe there's a complication of the stent that was already placed. So that's kind of my first thought, was the known bad things could be doing bad things. And then the next thought would be, could there be more bad news? And that's a picture here of Kevin Lawrence, who is my very wise senior a fellow when I was a resident here, who always said, sick patients do sick things. I paraphrased that a little bit. So this is a sick patient, so more bad things could be happening. And going right to the top of things to be worried about would be structural or mechanical problems, a post-surgical complication, bowel obstruction, leak, hernia. Could there be some other new infection, that it's not the C. diff, but some other problem? They're probably immune compromised with the cancer treatment, potential Crohn's therapies. So all kinds of potential bad infectious possibilities. Maybe now there's another kind of acute vascular event. I wondered if there might even be some new organ failure. Some other system is now going down, whether it's, and this is ascites development, so the liver's not working, the heart isn't pumping. There's generalized edema because the kidneys are not having nephrotic syndrome, so just some other bad thing there. More bad luck with another new cancer. Maybe now there's lymphoma or something weird like a neuroendocrine tumor popped up. And then a couple of things at the end that maybe you wouldn't think about right away, but patients with Crohn's disease sometimes get adrenal insufficiency, and that can have some different manifestations. And then this concept of swelling, I thought maybe that could be a clue for angioedema. And then the other thought was it's CPC, and sometimes you don't want to anchor to one diagnosis too much just in general. So could there be some element of misdirection, misdiagnosis? And that made me think of the things that she has. The one that may be the most vulnerable to being kind of mislabeled would be Crohn's disease. I think that's probably not likely, but listed on here, some of those ideas of things that you might get misdirected for Crohn's disease, and that would be kind of things that are therapy or drug-induced problems, radiation, NSAIDs, checkpoint inhibitors, again, pulling in infections, and then immune-mediated disorders like Behçet's vasculitis. Special shout out to amyloidosis, my favorite disease. I've got a nice big cognitive bias for that one. So that might be something that would be interesting if it were relevant here. And there is an association with AA amyloidosis and IBD. And then there's kind of all the things that don't neatly fit into some of those categories. So listed there with, I'm going to say I have that functional disorders at the bottom, whereas that is usually the cause for a lot of the problems I see. I think there's about 0 chance that this is IBS. Because the Rome criteria took a look at that one-liner and went, bye-bye. So that's kind of where we are.
Awesome. Very comprehensive differential, and we'll see if any of these diagnoses is the true diagnosis for this case. Moving on to the HPI. So over the past couple months, the patient's been experiencing worsening fatigue, weakness, poor PO intake, and she's been in and out of the hospital. Patient reports worsening abdominal distension, intermittent diffuse abdominal pain, and lower extremity swelling over the past 4 weeks. Given these symptoms, her IBD provider ordered an MRI abdomen and pelvis, which showed new ascites with peritoneal enhancement and septations in the pelvis. She's now presenting for expedited workup of this MRI. Medical history-wise, Crohn's disease complicated by chronic perianal fistula and abscess, as post-diverting loop colostomy. She has this T3 rectal mucinous adenocarcinoma that was diagnosed 1 year ago, status post radiation therapy, and abdominal perineal resection. Had negative margins, negative lymph nodes in that resection, and based on imaging 3 months ago, she was in remission. Recurrent C. diff infections, most recently 4 weeks ago, and a DVT and PE 4 weeks ago, status post thrombectomy, and is now on Eliquis therapy. Her current medications are azathioprine, Eliquis that was initiated 4 weeks ago with that DVT and PE, Skyrizi. She had her induction dosing 3 months ago. Previously, she was on Remicade, but was having still some inflammatory signs, so her IBD provider switched over to Skyrizi. And then fidaxomicin, which was initiated 4 weeks ago with that C. diff infection. Allergies, no known drug allergies. Family history has a sister with breast cancer that is BRCA positive. And then social history, she smokes half a pack a day for at least 39 years. Denies any alcohol or drug use. Moving on to review systems, she's had decreased appetite, fatigue, unintentional weight loss, about 20 pounds for the last 6 months, and then intermittent night sweats. Denies any fevers, chills, no respiratory symptoms, has this lower extremity swelling, but no chest pain or palpitations. And GI-wise, she has this diffuse abdominal pain that's not prandially associated, has increased colostomy output as well. Normally empties her ostomy bag 2 times daily, now emptying 4 times daily. She does say that the amount that she's had to empty has gotten better with the fidaxomicin. But denies any nausea, vomiting, melena, hematochezia, no bleeding, has this arthralgias, worse in the knees and ankles, denies any rashes, but has this kind of global weakness, she's been saying. And I'm going to give you the physical exam, and then I'll ask for your thoughts, Dr. Blaney. So she's afebrile on initial presentation, blood pressure 102/59, which is pretty similar to prior outpatient blood pressures. She's mildly tachycardic, heart rate of 106, respiratory rate of 20, satting 100% on room air. Her BMI is 16. She's cachectic, but no acute distress. She's tachycardic, but regular rhythm, no murmurs or rubs. She's clear to auscultation bilaterally on lung exam. On abdominal exam, she's diffusely tender palpation, has mild distension. Ostomy appears healthy, and on exam, there's some dark greenish semi-liquid stool in the ostomy bag, but no guarding or rebound tenderness on abdominal exam. On a gross skin exam, no obvious rashes. MSK, she has this bilateral lower extremity swelling that's present, and she just has this kind of overall swelling appearance. No deformities. She's AO times 3, no focal deficits, and strength and sensation are grossly intact on exam. All right, that's a lot of information, Dr. Blaney. What are your
Yeah,
thoughts?
well, it sounds like it's a little bit more of a subacute presentation. So, some of those acute surgical doom things are now moving back in the thought process. So we're really getting to, this patient is losing weight, failing to thrive, and has this new edema. So I think that's making me think, could there be something like a protein losing enteropathy, because now, that could go along with having this generalized anasarca. I think some of my amyloid stuff's still on the table because that one can do it. I hope I don't just talk about amyloid the whole time, but that was a thought. I think I'm a little worried that there could be something infectious, like a TB could go along with having ascites and these things. The fevers does make me think lymphoma, and being on the azathioprine may be a little bit of a risk factor there. So TB, lymphoma, my amyloid, like a protein losing enteropathy, potentially just the Crohn's disease, being worse as a thought too. So some of my initial thoughts. We'll want to, kind of get some laboratory assessments. Imaging will likely be needed here to help determine, some of the next steps. If there is a good amount of ascites, we'd probably want to tap that.
Is malignancy still on your differential or not? No.
Yeah. I mean, I think it is. I mean, she's a smoker. Like, could it be a peritoneal, like mesothelioma kind of strange thing? I think some of those options are definitely still on the table.
Let's take a look at her initial labs. So had a mild hyponatremia of 134, BUN mildly elevated at 26, creatinine 1.58, her baseline's creatinine 1.4. Otherwise, electrolytes are normal. Looking at her liver function test, T-billy, D-billy are normal. Protein is low, 4, and albumin is very low, 1.7. Alk phos is elevated at 706. Based on chart review, her alk phos has been elevated 400, 700s for the past couple months. AST normal, and ALT is mildly elevated at 53. Looking at CBC, her white count is normal. Hemoglobin 8.4. Over the past couple months, her hemoglobins have been ranging 7s to 8s, requiring intermittent transfusions. And then her platelets, over the past month since the thrombectomy, she's had this mild thrombocytopenia, but that's been stable on multiple checks since then. And there's a normal diff on white blood cell count. Do these initial labs help at all?
Yeah, I mean, I think, I was thinking they probably were going to be low on their protein, and that we see too, that alk phos is pretty elevated, with a normal billy. I'm thinking there may be some, hepatic congestion potentially, something infiltrative in the liver, could also be a consideration. They have some bad kidneys, so there could be nephrotic syndrome as part of why they're losing the protein, but with having the diarrhea too, you'd have to be worrying that you're having a protein losing enteropathy. That like kind of close to pancytopenia, there's a lot of things that could be going on there. You could have some of that being like azathioprine lowering your white count and things like that. The chronic anemia that's normocytic, there's a lot of problems that could be contributing to that as well. But the platelets being low, again, could point to there being a liver problem, or an underlying hematologic disorder. So again, like I'm still, not moving away from my amyloid.
All right, so still a lot of workup is needed.
Yeah.
So, Dr. Blaney, where would you like to start next? What would your initial diagnostics be?
I mean, I would want to see abdominal imaging because I want to get a better picture of the liver. What's the morphology? Does it look cirrhotic? Are the ducts dilated? I want to see if there's, how much ascites there is, if there's any, actual things that look like solid tumors or mets, you know, to get some things. So we would, you know, if you came through the ER, you're probably getting a CT scan, MRI may be a little better. So I'm not sure which you have, but you know, there'll be some scanning.
That is very true, but the CT scan is the scanners are busy right now.
Okay.
The so you were talking about the infectious bucket.
Yeah. Well,
What initial infectious labs would you
we're
want?
probably going to need to check for that C. diff again. You know, sounds like we're meeting the criteria of being worried about that being a bad player. Although I don't think that that would necessarily contribute to some of those other lab findings that we've got. I would check those light chains because I like to see that. Probably needs to have some sort of a TB check if they haven't had that on file. You know, usually patients that are on biologic get pre-screened for that. And then what else? What else do you want?
What about like immune status, like maybe HIV or
We should check that too. Yeah.
all right.
The differential gets a little wilder if you do have underlying HIV.
All right, I can give you some of those labs. So blood cultures were negative, HIV negative, acute hepatitis panel was also negative, C. diff negative, and UA non-infectious. So
Do we know if on that UA we're losing a lot of protein or no?
there was 1+.
Okay, so some, but not.
All right. So I hear that you want to scan, and the CT scanners are now up and running.
Okay.
So we have our expert radiologist, Dr. Schumacher here to talk through the CT. He did his medical school at University of Miami, Leonard M. Miller School of Medicine, did his medicine internship at University of Miami Jackson Memorial Hospital, and his radiology residency at Loma Linda University Medical Center. He's currently an advanced abdominal imaging fellow at WashU's Mallinckrodt Institute of Radiology. Please help me in warm welcome with Dr.
Thanks for that introduction. Okay, so we got a CT of the abdomen and pelvis, and it showed small bowel wall thickening that was most prominent in this proximal small bowel. And then there was also moderate to large volume ascites. But then to address your concerns, there's no evidence there's no like cirrhotic features of the liver, and no evidence of metastatic disease.
All right. So it seems that we don't have like obvious, you know, cancer exploding in all the organs everywhere, which is good. And it sounds like there isn't like obvious peritoneal like studding or features there that, you know, we need to worry about. With the small bowel wall thickening, you know, there's a lot of things that could do that. That could be her Crohn's disease. It could be an acute infectious enteritis. It could be my amyloidosis. There's a lot of ascites, so I think we are going to need to sample that and get fluid studies to help delineate if we're talking about, you know, liver disease versus cardiac versus does it look malignant? And, you know, I think we're probably heading towards attempting a scope to get tissue sampling of that inflammatory or that inflamed looking small bowel, just because if the stool tests are negative, we're thinking it's maybe not an enteric infection.
Gotcha. So maybe malignancy is a little bit farther down the differential with this imaging, you'd say?
Yeah, I mean, at least like solid tumors are moving down.
Fair enough, fair enough. All right, so I hear paracentesis. Is that what we're thinking? All right, so the
I was gonna say, are you gonna make me do math?
I know, the math's easy on this one. So the paracentesis studies was the fluid was white, turbid, less than 2,000 RBCs, only 44 nucleated cells, of which 37% neutrophils, 17% macrophages, 46% lymphocytes. Ascites albumin was 0.2, serum albumin of 1.6, so the SAG was 1.4. And then the ascites triglycerides was 366 with the serum correlate of 149.
All
What
right.
are your thoughts?
So, it looks like it's a high triglyceride ascites. So, Achilles ascites, there may be something obstructive happening with the lymphatic system. I think this could be a little tricky to pin down with the imaging that we have. We might end up needing an MRI. But I think it'll be interesting. I think maybe I don't know if you do the thing that's for the TB, the ADA, or
Unfortunately, we didn't get
Okay,
any
I don't know.
ascites.
curious. And then did they do any cytology?
They did.
Okay.
So culture, aerobic, anaerobic culture were negative, and then cytology on 3 different paracentesis were negative from.
Well, you guys were really looking for the. Okay. All right.
So I have to ask Dr. Blaney, with 3 cytologies being negative, does that effectively rule out malignant ascites?
And no test is perfect, but it's sort of steering you away.
Yeah, exactly.
I think we're back to maybe we go fishing in the small bowel for tissue.
All right, so thinking endoscopy at this point.
Yeah. I mean, we like scoping, right?
Fair enough, fair enough. Well, we called GI consults and they are just backed up. The endoscopy lab we're not going to be able to get a scope for another week.
Sounds legit.
So, yeah. So I hear this concern for amyloid. What kind of workup would you want, rheumatologically, immunologic wise?
Well, if it is amyloid, it doesn't sound very likely to be the hereditary type, which you can have a gene test for. So what we're looking for, if we're thinking of the light chain variety, is if there are elevated serum light chains and a positive immunofixation for a clonal protein. We used to do the SPEP a lot, but we kind of moved away from that. You can also look for if there's an abnormal urine protein, so the UPEP may be helpful too. Sometimes patients will need a bone marrow assessment. And in general, with amyloid, you like to get tissue biopsy that you can do staining for Congo red. And our kind of adage is to biopsy the potentially affected organ. Fat pad biopsy is an option, but we don't do them as much as in the past. Again, if you think there's kidney disease, take a kidney biopsy. Heart involvement, get an endomyocardial biopsy. And for me, I'm wanting a GI biopsy.
Gotcha. And then are we thinking about any inflammatory labs for that potential Crohn's flare or? I
mean, it wouldn't hurt, but I don't know that it's going to change a lot of what you do. So you certainly could check your, and we talked about PLE. You probably would want to check a stool alpha on antitrypsin to see if you have, an altered clearance that does suggest you're losing the protein through the gut. So I would like to see that. Fecal calprotectin could be helpful, but I just don't know that it's going to change what you do. So if you have it, great, but I wouldn't press for it. And then inflammatory markers, this patient's just so sick. I don't know how helpful it would be, but.
That's fair. Well, I can give you some of those labs. CRP was elevated at 57.5, and it's been elevated on multiple checks over the past couple of months. ESR is normal. They did get an SPEP, no apparent monoclonal protein, had a polyclonal increase in gamma globulins. Kappa and lambda light chains are both elevated, but the kappa lambda ratio is normal. And then UPEP had no monoclonal protein.
So that, the light chains are elevated, but that may be more just because her kidneys aren't happy. And with it having a normal ratio, there's not a predominant clone. So that does maybe argue against light chain disease.
Gotcha. So amyloid off the differential at this point, or
never
off the differential? Fair enough. And then you were talking about the protein losing enteropathy.
Yeah.
You talked about getting a stool alpha-1 antitrypsin. Anything else that you'd like to investigate the protein losing enteropathy with?
Yeah, I mean, I think sometimes we'll see, like, if we think that there's something kind of mechanically disrupting the lymphatic system, like a MR lymphangiography may be helpful. So that would be probably under your advanced imaging kind of tab there. And we do have great radiologists that can do that kind of fancy test for us.
That's fair enough.
And that might explain too, like if the lymphatic system is damaged or disrupted, why she's having the colitis ascites, like, there's a leak somewhere, and it could be leaking in the gut and leaking into the abdomen.
Gotcha. Well, I can talk with you about the protein losing enteropathy. We did get an alpha-1 antitrypsin stool and a serum. The stool alpha-1 antitrypsin was 164, which is pretty elevated. The serum alpha-1 antitrypsin was 137. Now, these are both spot tests, so they aren't the clearance. We didn't get a 24-hour stool collection to calculate the clearance. Just having these spot tests, is that enough for us to say this is protein losing enteropathy?
I mean, I think it's pretty suspicious. I don't know how much more your testing, is more sensitive if you do the full workup, but it's interesting that it seems like the serum's normal, and then, if you're still having like a high amount in the stool, that ratio would suggest you're losing it. Yeah.
And just for further workup for the hypoalbuminemia, the team did get a 24-hour urine protein, which is 494, which is not nephrotic
Not
range.
horrible.
And then just for the swelling, they did get an echo, which was unremarkable, and NT-proBNP was normal. I did want to ask, for protein losing enteropathy, since we're highly suspicious of this with the stool alpha-1 antitrypsin being as elevated as it is with a normal serum, does that change your differential, or is it just kind of a non-specific thing that could be anything?
Yeah, I mean, there's a whole kind of list of things that can do that. I mean, it can be an association with IBD. It can be a primary lymphangiectasia process in the GI tract. We tend to see that in younger patients, though. I've seen a few patients who had an underlying HIV or something where, they've maybe had an MAI infection in the gut, and that led to changes in the lymphatics that perpetuated protein losing enteropathy, or things that are like diseases of the mesentery, like an inflammation there, squeezing off the lymphatics. Might have expected you might have seen some of those changes on the CT, but I think there's several things that can do that. So it does help us kind of move away from certain things, but doesn't put a pin on what's going on.
All right, Dr. Blaney, I know that you said endoscopy. We're not quite, the GI fellow said that they had some GI bleeders, so
Okay.
it's not available yet. Is there anything else that you'd like to do in the meantime while we're waiting for that endoscopy?
I mean, I'm starting to put my money on needing to see like lymphatics imaging. I don't know if this could be like a delayed surgical complication, or what could have damaged the lymphatics that is leading to this presumed leak. But I would say maybe the imaging.
Yeah, and so oncology was actually involved at this point, just given the MRI abdomen pelvis prior to presentation. They were very concerned still about potential metastatic rectal cancer or recurrence. So they actually recommended for us to get a PET CT,
Okay.
which we'll go over now. We'll welcome back Dr. Schumacher to go over that.
Okay, so we have a couple images of our PET CT here. We do have these, a few non-enlarged lymph nodes that are very FDG avid. This one is a peripancreatic lymph node. On this coronal view down here, we see that in the retroperitoneum, there's these several, again, non-enlarged lymph nodes that are active on FDG. There is, along the left peritoneal lining in the pelvis, there is a little bit of thickening that we can see on the CT. And there is a little bit of FDG activity with that. And then when we look more closely at the small bowel, we have this persistent persistent thickening of the proximal small bowel wall with prominent FDG activity, especially related to the rest of the small bowel. And then moving up into the chest, we have this it's kind of borderline enlarged left supraclavicular lymph node that is also FDG avid.
So we have a lot of things that we could potentially try to go getting tissue, since our repeated attempts at getting cytology help have failed. You know, and it's, I think, going to come down to what do we think is the most like useful but, you know, feasible way to get some tissue. I would think that peritoneal thickening may be a little difficult to access, although that could be interesting to know what that is. Some of the lymph nodes would potentially be, you know, in an area that an EUS could access. I think getting a direct look at that diseased small bowel would be very helpful. And that I'm not too excited about that left supraventricular node being like the linchpin of the case. So I'm going to say pass on that.
So you're exactly right, Dr. Blaney. You know, the tissue is the name of the game, and oncology really wanted us to get lymph node tissue. They actually did end up going for that left supraclavicular lymph node.
Wow, that's,
So,
does it tell the answer?
we'll see. We'll see. They did do an ultrasound.
That is probably one of the easier spots.
Yeah, yeah,
Just be like,
yeah.
all right, we'll take a sample.
Yeah, exactly. So they did an ultrasound guided fine needle aspiration of this left supraclavicular lymph node. And to discuss the pathology of the fine needle aspiration, we have an expert pathologist, Dr. Margaret Axelrod. Dr. Axelrod did her medical school training at Vanderbilt University School of Medicine. She's currently a pathology resident here at WashU. Thank you so much, Dr. Axelrod.
All right, so we have an FNA specimen of our lymph node here. This cute little guy is a granuloma. You can see all these cells lining around the outside and all this swirling. These tend to pull out quite nicely on FNA. And shown here in flows on other slides, there's a little bit of background lymphocytes that tells us we're in the lymph node. So we saw that we also didn't see anything else. We didn't see any evidence in metastatic carcinoma. One thing that's important for you all to know when we do FNAs, what smears out on the tissue stays on that slide, and we take separate passes that we spin down in a cell block, and then we can only stain what's on that cell block. So this is our cell block. There's no granuloma there. We did do bug stains, which we would kind of expect to be negative because there's not a granuloma there. So at this point, we can't really help as to whether these are infectious or non-infectious granulomas, but we can tell you there's not metastatic cancer in this supraclavicular lymph node.
All right. Well, now I'm thinking maybe sarcoid. You know, that could be infiltrating the liver. It's a little weird, right, that this would be heading in that direction. But, you know, these.
Did you see sarcoid infiltrate the small bowel like that? Or is
I mean, I haven't seen it, but I mean, maybe it's another one of those, it does what it likes.
That's fair. That's fair. All right. We finally got a call from the endoscopy lab and they're ready for the patient. So we're rolling them down.
About time.
Yeah. So they ended up doing a upper endoscopy, a small bowel enteroscopy. The report read LA grade B esophagitis, normal stomach, diffuse severe mucosal changes in the duodenum, characterized by congestion, erythema, friability with contact bleeding. Now, Dr. Blaney, I'm not a GI doctor, but this looks very abnormal.
That looks very abnormal.
Yeah.
Yeah. Really what they just say, you know, it's all you can really say is like a descriptive change, you know, because it doesn't look, you know, like a slam dunk for any specific diagnosis. It's not typical for Crohn's disease, that's for sure. But it could be one of our infiltrative disorders, like all the things that we've already kind of talked about, lymphoma, amyloid. Maybe we're tossing in sarcoid now.
So pretty much it could, the differential is still incredibly broad at this.
Yeah, but I think I'm optimistic the path will be really helpful here.
Mhm.
I mean, I don't think it looks like a Whipple disease. That's another weird thing that sometimes we find in the duodenum, but I just don't think that necessarily fits.
Gotcha. Well, we won't have to wait long for the pathology results. We got our expert pathologist, Dr. Axelrod, to go over the small bowel biopsy.
Okay, I just included these same pictures of the endoscopy because we tend to look at these as well. So here's a picture of the small bowel. So right away you can tell there's some stuff in between the glands that looks like it shouldn't be there. The glands themselves look more or less okay. They're a little squished by this infiltrative background here. And on a little higher power, we can see all these big pink cells in between the different colonic glands, or sorry, small bowel glands. And these are macrophages. You can tell because they have this nice fluffy cytoplasm, and they're just filling up the lamina propria here. So a little higher powered here. And when we see this histologically, our differential diagnosis would be something like Whipple disease versus something like MAC. Those, or also something else infectious could do this as well, but those are the most characteristic for causing diffuse lamina propria infiltration with these macrophages. So we can do some special stains to help us out with that. So we did an AFB stain, which is very diffusely positive. When I look at these in the lung, we get like 2 cells that are positive. So this is very easy to interpret. These, as you can see, hopefully nicely here, all these little specks are acid-fast bacilli. So that makes us most suspicious for MAC. We did a PAS, which would be positive in Whipple disease, which was negative. We also requested a Congo red, and I think that's a very good thought, but was negative and not really fitting with the morphology that we saw in H&E. So here we see this confluent macrophage infiltration in the lamina propria with acid-fast microorganisms, most consistent with MAC, though, additional cultures would be needed to confirm that.
Okay, so, like I said, I had a couple of those cases where HIV patients had MAC that damaged their lymphatics. But I guess in her case, it's the immune compromise from her other comorbidities that potentially put her at risk for this. Do we have her labs to know, was she really low on her CD4 and some of those traditional things that
We never got a CD4.
he was kind of mildly
But she was on the border.
low
being,
lymphopenic? Yeah.
Yeah.
Interesting.
So do you think that this infectious cause is the sole reason for her current presentation, or could there be another thing going on?
I think that the MAC is clearly probably going to be linking to the PLE, and it's damaged the lymphatics. That's why you're getting the colitis ascites, and the protein losing enteropathy that's going along with all this. And when you get PLE, you just get so depleted in everything. I mean, you lose lymphocytes, you lose important stuff besides just protein. So, I mean, patients feel like garbage and are just generally sick. So I think it certainly could explain, the bulk of what we're seeing here.
Awesome. So we have acid-fast microorganism. So we're likely looking at a mycobacterial species. While we're waiting for the culture and PCR to come back, we did get a T-spot, which was negative, so ruling out TB. AFB blood culture was negative, and then the duodenal biopsy tissue culture was actually negative as well. Now, weeks later, the duodenal biopsy PCR did yield a Mycobacterium genevense. So this is a pretty rare, infection for
Good
someone
CPC.
So taking us to home stretch, what would you say the diagnosis in this case is, Dr.
I
Blaney?
think that the patient had severe comorbid conditions that put her at risk for being significantly immune compromised that allowed her to get this MAI infection, which damage the bowels and the lymphatics leading to PLE.
Absolutely. Thank you so much, Dr. Blaney. All right. Well, given the negative lymph node, fine needle aspiration, positive PCR, oncology determined there was no evidence that malignancy was playing a role in this hospitalization, and that active infection is more likely to explain the imaging findings with lymphadenopathy and such. Patient was initially treated with rifampin, moxifloxacin, azithromycin, and ethambutol. Weeks later, once the molecular PCR came back, antibiotics were switched to rifabutin, moxifloxacin, azithromycin. Repeat imaging months later showed significant improvement in lymphadenopathy consistent with treatment response with antibiotics. So this particular mycobacterium typically affects immunocompromised patients, especially those with HIV and AIDS. Biologics, especially infliximab, have been associated with mycobacterial infections, including non-tuberculous mycobacterium infections. This species' major clinical manifestations include abdominal pain, hepatosplenomegaly, and abdominal lymphadenopathy. Per the ATS-IDSA guidelines, treatment includes a multi-drug regimen with a combination of macrolide, either azithromycin, clarithromycin, rifamycins, rifampin, rifabutin, fluoroquinolones, amikacin, and or streptomycin, but optimal therapy has not been determined at this time. Mortality rates are still pretty high, 32% to 44%, with macrolide-containing regimens associated with improved survival. So,
And that supraclavicular lymph node was just a wild card red herring.
It was, yeah. You saw right through it. Well, that's CPC. Thank you everyone for coming, and thank you so much, Dr. Blaney, Dr. Axel, Dr. Schumacher. Thank you, Dr. Blaney. So not amyloid.
Not